Hello and welcome to Prescribe Responsibly, the podcast where we explore ways we can make smarter, safer, and more effective decisions about how we use antimicrobials and where we discuss innovative solutions in infectious disease space. I'm your host, Dr. Ari Frankel. I'm an infectious disease physician and epidemiologist, and today we're diving into a topic that is reshaping the landscape of modern medicine, antimicrobial resistance, or AMR. AMR happens when bacteria, viruses, or fungi evolve to resist drugs designed to kill them. It's a silent but growing threat, leading to longer illnesses, more complicated treatment, and in some cases, life-threatening infections that no longer respond to standard antibiotics. To help us understand what this looks like on the front lines, I'm joined by Dr. Zachary Mostel, an infectious disease physician specializing in transplant medicine. Dr. Mostel, thank you so much for joining us on our first episode of the AMR Report. It's great to have you here.
Thanks for having me, Ari. The pleasure is all mine.
So let's start with just some background. What is it about infectious disease that drove you to specializing in it?
So microbiology was my favorite part of the first year of medical school. I loved the problem solving that came with these challenging, mysterious cases. Around the same time, I became interested in global health work and found myself in countries like India, Ethiopia, Rwanda, and I saw these masterful clinicians who were treating infections like HIV and tuberculosis with very limited resources. And I wanted to be like them. I was inspired.
Wow. We have to dive in maybe in another time on your experience in developing countries. But what does your day-to-day look like here? What are you seeing in regard to AMR, and how does that change some of the infections you're seeing and how you manage them?
Yeah, so the most common drug-resistant infections I see on a day-to-day basis is called extended spectrum beta-lactamase producing Enterobacterales. It's a mouthful, or ESBL you'll hear often for abbreviation. The challenge with these cases is that they often do not have oral options for antibiotic therapy, and they'll need IV antibiotics to go home. For example, I've seen several young, otherwise healthy patients over the last few weeks with this type of infection. All it really takes is a few rounds of antibiotics for UTIs to get to that point of AMR, and it's a shame because they have a lifetime of potential future encounters with the healthcare system, and they'll have fewer treatment options. The challenge of these cases is actually more logistical in real-world settings. You need to coordinate between social workers, infusion companies, insurance companies, the nurse who has to come infuse the drug, mail delivery systems. So really, that is the challenge, more practical than anything else.
I can see that being a serious problem because now patients have to go home with an IV line put in place, which also leads to difficulties. Do you
That
find
as well.
that transplant medicine complicates this more?
Yeah, recipients of organ transplants are very often heavily treatment experienced when it comes to antibiotics, both before and after the transplant. They're quickly colonized by multi-drug resistant organisms, and they become quite skilled in using home antibiotic infusions. The challenge in transplant medicine is that these patients can get very sick very fast, so it is preferable to have a full menu of antibiotics at your disposal and not fewer.
Do you find that resistant infections change the way you approach day-to-day treatment decisions? For example, you mentioned ESBL. Do you skip standard therapy now and go straight to the big guns, so to speak?
So I'm much more conservative than many of my colleagues when it comes to antimicrobial stewardship. If the patient's in septic shock, I go straight for the big guns. The stakes are high. That's fair enough. If I have the luxury of time and a stable patient in front of me, I favor things like ceftriaxone or ampicillin-sulbactam, which are now considered narrow spectrum, but not long ago were considered the big guns.
Do you find that there's a general awareness regarding this AMR issue among non-infectious disease physicians in the place that you currently practice? Do you often encounter excessive antibiotic use from non-infectious disease doctors?
There is awareness of AMR across the medical community. That does not translate to actual practice, though, and you will see excessive antibiotic prescriptions in all kinds of medical settings. There was a great study in CID in 2024 where the authors actually went undercover and ordered antibiotics from this direct-to-consumer telehealth company for inappropriate indications. And it showed how effortless it was to acquire patient-selected antibiotics online. I encounter excessive antibiotic prescription every day, and I'm frequently counseling patients that they are unnecessary, and that's what I've been seeing.
Wow, that's unfortunate. What is it you think healthcare providers are missing, or why do you think they're still inappropriately prescribing antibiotics?
I think there's two reasons. The first is pressure from hospital leadership in line with CMS, that's Centers for Medicare, expectations. There's also ER culture of ensuring timely antibiotics, and all that comes at the expense of stewardship. The second reason would be that there's also pressure from the patients who demand antibiotics when they may not need them, but doctors fear both bad patient satisfaction scores and also fear essentially doing nothing for the patient, to put it politely. So the patient and the doctor feel better that they gave the patient something, even if it's not indicated.
Right. So there's a lot of forces in the environment pulling away from stewardship. Do you think if there's a particular intervention that, if put in place, may reduce the overuse of antibiotics? For example, antimicrobial stewardship programs are mandated in hospital and long-term care facilities, but do you think this is helpful? Is this actually working? And from your experience, do healthcare providers have the access to infectious disease expertise that they need?
Great question. So antimicrobial stewardship programs, or ASPs, they do a fantastic job of curtailing both unnecessary and overly broad antibiotics. As fellows, we rotated coverage of the antibiotic approval pager, and it was highly educational, but it was also very time consuming to go through hundreds of requests for things like piperacillin and tazobactam. ASBs are effective, but they require a ton of infrastructure and manpower to implement them effectively. You usually see them at large academic centers and not so much at community hospitals.
It's interesting to note that some studies show that 80% of counties in the United States don't even have access to an infectious disease doctor. So I can imagine that their stewardship program is probably lacking as well. When we zoom out to the public health and a global perspective, do you think the public fully understands the threat of antimicrobial resistance? You mentioned a lot of patients are asking for antibiotics. What are your thoughts on that?
The public awareness of AMR is similar to the provider's awareness of AMR. They've heard about it on the news and may have a simpler understanding of it than their doctors, but there is cognitive dissonance when it comes to their demands for antibiotics when they have anything resembling a viral upper respiratory tract infection. Breeding resistance isn't as important as that azithromycin that they need right now.
What kind of policies do you think can be implemented on a public health level that could better support clinicians and the public awareness on combating AMR? I know that the CMS and the Joint Commission and other governing bodies have put in place mandatory antimicrobial stewardship programs in facilities. Is there anything else, in your opinion, that might be helpful?
Yeah, going back to what I was saying earlier, so CMS and healthcare systems need to reward stewardship efforts better for the use of narrow antibiotics. They need to put decision-making back in the hands of the frontline providers without the fear of penalization for not giving vancomycin to a 20-year-old female with mild COVID. I actually saw that with an ER doctor who gave that once because she had, quote, sepsis, and I still can't get over it. It touches on what we were talking about. There's this feeling that you're doing the patient a service by doing something, by giving them an antibiotic, but in reality, you're just wiping out their microbiome, you're breeding more resistance, and causing more problems in the future. I had one mentor in the ICU who used to joke that there is nothing worse than dying. That's the worst. So
Right.
give them something if you feel like they need it and you are going to try and
Right.
keep them alive. But once you've figured out that it's not necessary, peel it off as soon as possible.
Yeah, it's that philosophy that if we can, then and we have the means to do it, then do it. Even though with ID it's the exact opposite. That sometimes the opposite's true. Not giving antibiotics is better for the patient. It's very hard to get outside of that mentality where you want to pull the trigger, because this sense of, if I'm not giving it, I'm doing something wrong. So I'll give you everything. I'll just in case measure, and then we'll see what happens. Even though that sometimes hurts the patient. Not only that, it hurts the case, because sometimes antibiotics are given before the workup even happens. You'll have patients on antibiotics. It's like, so did anybody do blood cultures? Did anybody take urine? Did anybody do respiratory workup? Nothing. And the patient's been on antibiotics for several days, and then ID is called to manage. It's like, well, now I'm going to have a hard time finding what's going on here.
And that's the culture in ICUs across America, is to not to do blood cultures. You'll hear this over and over. There's some outdated cultural stuff going on in the ICUs everywhere where they do not do blood culture because of the fear of getting dinged for eclampsia. But in reality, there's nothing worse than dying of gram-negative sepsis. So if you miss that, it'll definitely be more expensive than the eclampsia that you're getting charged for. So I've been telling a lot of the providers in the ICU that if you're going to start meropenem on a patient, you should be drawing blood cultures first. That should just be a standard policy.
That's the standard. Right. It seems that's intuitive, but it's really not. And you see it across the space. For example, nursing homes also get dinged on UTIs and any type of healthcare associated infection. So the mentality is work up less, and then we won't find these things. But the patient eventually gets sicker, has to be discharged, admitted to a hospital, and then you get your Medicare ding from that angle. So you're not saving yourself. Ultimately, it comes to a head. Same thing with C. diff. I remember there's protocols put in place to reduce the testing for C. diff. So rather than rule it out, they don't want to have a false positive too. So they're trying to toe this line of less testing means less dings, means less healthcare associated infections, but the patient in the end, if you miss something. So how to balance that with doing a proper workup, risking the fact that there can be a false positive, but then also not going down this road where they don't do any workup. And now you have patients who are sick and we have no idea what's going on, and antibiotics have already been started.
Yeah, totally agree.
Before we wrap it up, let's talk about the future. AMR is a doom and gloom, silent pandemic heading our way. But I think there's some optimism. Are there anything promising, new tech treatments or technologies you're excited about? What gives you hope that we can turn the tide on antimicrobial resistance?
Two things I've seen I'm very excited about: phage therapy and T-cell therapy. They're under study, and there are new ways to treat infections without all the drawbacks and potential side effects of antimicrobials. Very promising research into both of these modalities, and I'm excited for what comes of them during my career.
Thank you. We appreciate your insights. Thank you for sharing your experiences with us today. It's clear that antimicrobial resistance isn't just a distant threat, but it's here, it's growing, and it's reshaping the way we care for patients. But as you've shown, there is some hope. Through stewardship, innovation, and collaboration, we can possibly preserve the power of antibiotics for generations to come. And for our listeners, remember that responsible prescribing and responsible use of antibiotics are something we all play a part in, whether a patient or a healthcare provider or a caregiver. The choices we make today can shape our future of medicine. Thanks for tuning in to this episode of Prescribe Responsibly, the AMR Report. If you found this conversation helpful, please follow, rate, and share the podcast. Thank you, Dr. Mostel, for joining us.
Thanks again.